Thank you, Professor Azad Khan. It's a great honor that you are chairing this session and that this is a DASG session of which we are two people who have been long in this field. I'd like to thank the organizers for inviting me to present. So I'm going to talk about a subject called as early gestational diabetes. And we'll talk about what that early is. I have no conflict of interest to declare. There are two major studies which I'll be talking about. One is a STRIDE study, which is funded by the UK and the Department of Biotechnology in India, and the other is a toboggan study from Australia, for which we had no funding at all, but we are part of it. So getting straight into the subject, what is early GDM and why is this term early GDM used? Gestational diabetes for many years was considered a type of diabetes which comes during pregnancy. It's actually, the strict definition is first diagnosed during pregnancy. That could also include people who did not know that they had diabetes when they became pregnant. But strictly speaking, gestational diabetes is something which comes due to the gestation, and therefore it was believed that the baby has to grow, and therefore only in the second or the third trimester they develop diabetes, and therefore most of the international organizations today, including the Indian organizations, suggest the screening for GDM between 24 to 28 weeks of pregnancy. However, more recently there has been evidence that gestational diabetes can actually occur in the first trimester of pregnancy itself, and that is why we call this as early GDM. So if you call this as early GDM, then what would you call the one which you use to diagnose? Obviously late GDM, isn't it? So therefore, based on the type of the gestational diabetes, based on the timing of the gestation, you can have early GDM, and for convenience we have called it as less than 20 weeks of gestation. There is no strict rule for that, because in the toboggan study we used 20 weeks, and therefore before 20 weeks if a woman who is pregnant is diagnosed to have diabetes which is occurring for the first time, we call it as early GDM, and if it occurs later, 20 to 28 weeks, we call it as late GDM. So you have the early GDM and the late GDM. How do you diagnose early GDM? That's a good question, because we still don't have the answer to that. Many years ago in 2010, based on the HAPO study, the International Association for Diabetes Pregnancy Study Group, the IADPSG for short, they came up with a definition that if the fasting plasma glucose of a lady during pregnancy is between 92 to 125, that can be called as early GDM during the first trimester of pregnancy. Now the 125 you can understand, because 126 become diabetes. The fasting blood sugar of 126 is diabetes. So then that's diabetes complicating pregnancy or diabetes in pregnancy. But where this 92 came from is actually from the HAPO study, where they had used the 1.75 cut point to see the fetal outcomes, various fetal outcomes, and there the fasting came as 92. But the moment this was proposed, there was a lot of opposition. They said this 92 is too low, because too many women will be diagnosed to have gestational diabetes. So they withdrew it. They withdrew it and they said, well, we don't know what is the diagnostic criteria. So this 92 always was debated, and I'll tell you later that it seems to be slightly higher, and I'll come to that later. Now, one of my PhD students, Hannah, when she joined for her PhD, we gave her this topic of early GDM and told her, you work on this. So the first thing a PhD student should do is to collect all the literature on the subject, so that you know every paper published in the world. So that's what Hannah did in this paper we published in Acta Diabetologia, a systematic review of every paper published in the world on early GDM. I'm not going to go through everything, I'll show you one or two things, but What we found was that it's a total mess, as one would expect, because there is no diagnostic criteria, there is no treatment suggested, nobody knows what it is. So everybody who had said early GDM, anybody who had diagnosed something in the first trimester called it as early GDM. So there were 58 studies which were included, and look at the prevalence rate of GDM. One study had said it's 0.7% of all pregnant women. Another study said it's 37%. So you can imagine the wide variation. If you look at risk factors, the obvious risk factors came out: BMI and previous history of GDM, family history of diabetes, multiparity, etc. And there were studies which reported on birth outcomes, and just like the late GDM, or what we earlier used to call as the conventional GDM, there was macrosomia, cesarean delivery, shoulder dystocia, and so on. But there were some interesting points which came out. In the limited studies which are available, it looked as if this early GDM was a little more severe than the conventional or the late GDM, because the need for insulin is higher. And when you looked at the conversion rates of those who later became diabetic, it looked as if these early GDM people seemed to convert more. But as I said, it was just a systematic review of published studies, and there were a lot of discrepancies in the data, but this is what it seemed to suggest. So it was very clear that a lot more work was needed on early GDM. Before Hannah had started her work on early GDM, we had already started a study with the UK, and that is called as a STRIDE study. STRIDE stands for Indo-UK-Kenya study. So the 3 continents and 3 countries involved: India, UK and Kenya. So Europe, India, and UK, India and Africa were involved in that. STRIDE stands for Stratification of Risk in Early Pregnancy. Now, what is the aim of STRIDE? The aim of STRIDE, that time we didn't bother much about early GDM, we didn't know much about that. So we said, okay, women are going to get diabetes in the second trimester. Why should we wait until then? Can we start looking at them in the first trimester and predict who is going to get in the second trimester, rather than get a shock, oh, you got in the second trimester? Can we start looking? Can we look at their age or BMI or glucose or whatever, HbA1c or whatever, and say these are the women who will develop? So that was the whole aim, to develop a risk score, and indeed we have developed a risk score to predict who will develop as a part of STRIDE. And STRIDE was a large study. Normally the GDM studies are 50, 100, 200. Here we had 3,000 women between the ages of 18 and 50. There were a lot of sites. I'm talking about the India sites now. So Chennai was obviously the center, and we had Sitapati Clinic where Dr. Uma Ram, our obstetrician, who also runs the EV Kalyani. Then to get women of different socio-economic status, Uma Ram's clinic is a little higher income group. EV Kalyani is slightly lower, Andhra Mahila Sabha is even lower, VHS is even lower. So we had all the women from the lower to the middle to the higher socio-economic status. Then we had Fernandez hospitals in Hyderabad, which is middle to upper class. And then we had JIPMA, which is the lowest, people from villages, the lower SCS. So it's a true representation of early middle class, lower middle class, and you can find the people there. That's Umaram in the green sari, and Saravanan Ponuswamy is there, and he was the leader of this particular study based in UK, and all my other team members including Hannah are shown there. So what we did was, we took these 3,000 women. Some of them did not come for proper follow-up and so on. They didn't enter into the study, so we had to exclude them, 300 of them. So we had 2,700 of them. So what we did was, since there was no other accepted criteria, we followed the IADPSG criteria itself. So we said, okay, let's do a fasting glucose and we'll do an A1C. Now when you did the fasting glucose, few of them, I don't know if this will work, let's see. No, it's not this one. No, it doesn't work. Okay. So a few of them had a fasting glucose above 126. So they are diabetic. Okay. So we excluded them. Interestingly, we had only 8 of them. So we excluded them. Then some had below 92. So they are normal. Then there were some between 92 to 125. Now that's early GDM. So we had this group of early GDM, about 566 women whom we could study. So it's one of the largest series of early GDM in the world literature actually. Then if you had fasting less than 92, they are normal. Now what do? We wait for second trimester and then we do the GTT again. We again use the ADPSG criteria. Now two things can happen. They can still be normal and therefore they are normal. And then we had late GDM because they did not have early GDM. Now they have late GDM. Okay, so now we have three groups now: normal, early GDM and late GDM. Now this gave us a chance to compare early GDM and late GDM in the same study. So if you look at this, it's just been being submitted for publication probably this week. So what we found was that if you look at the early GDM, forget about the normal women, look at the early GDM and the late GDM, you will find that the BMI is slightly higher, the waist circumference is slightly higher, 89 and 87, the glucose level fasting is slightly higher. Look at the A1C, 0.1 higher. So this is not diabetes, because some of you will say, well, they are all diabetic. No, they are not. 5.3 is not diabetes, okay, but they are slightly higher, definitely higher than the normals, but also higher than the late GDM. And the glucose and the venous A1C, we also did point of care A1C in case we had to do it in rural areas later and so on. So it confirms that these early GDM women are slightly more severe in their glucose intolerance than the late GDM. Now we are able to look at the risk factors. Who are these women who develop this early GDM? Those who had higher BMI, those who had higher A1C, and those who had GDM earlier in a previous pregnancy. These were the risk factors. A series of papers of STRIDE are being written, but the first one was published last year in Lancet Diabetes. And here what we tried to do was, we set out with the question, how can we predict who will develop late GDM? That is the whole idea behind doing STRIDE. It turned out, and in the UK, they don't like to do GTT at all. They hate GTT. Okay, and the US, they completely hate GTT. In India, we have no problem. We can do GTTs, no problem. Women will come. But apparently the UK women won't come. We heard recently at the Gates Foundation meeting 2 weeks ago in Copenhagen that Swedish women will come, Danish women will come for any GTT, Indian women 100% they will come, but UK women will not come for GTT. So the first thing that Saravanan Purnasamy wanted to do was to say how many GTTs can we avoid. So it turned out that if you do the HbA1c, and the advantage of HbA1c, of course, you can do it at any time. You don't need fasting, you don't need anything, you can do it any time of the day. And you can do it with point of care, you can do it with lab, you can do it with anything. So it turned out from this paper, very important paper, which says, okay, if you have HbA1c of 4.9 or below, they will not get GDM. So you don't need to screen them at all. So that way it's useful. If it's 5.4 and above, they almost certainly have GDM. So probably they don't need a GTT because they're already in the GDM range. So only those who are between 5 to 5.3, they need to go for a GTT. So they are very happy that 50% of OGTTs you could avoid. But just doing a non-random, non-fasting HbA1c helps them to eliminate. We also found out an equation here. In the paper, if you read it carefully, we have found out an equation. If you use HbA1c, age, something, and do a formula, you can predict who will get GDM in the second trimester. So that is a major contribution of STRIDE, but many more papers are being written. But now let's come back to early GDM. Okay, so there is an entity called early GDM. Is it safe to treat these women? That's something we don't know. There's no proper randomized study has been done. You picked up these women. There is no study which has done looking at treating them or not treating them. How do you know that treating them is safe? Suppose you go and treat something, a new entity, and then you go and treat them and they do worse, then you should have left them alone in the first place. So there were small studies which were very non-contributory and small sample size. So we had to do a proper randomized study to show that treating early GDM is safe and it is effective. So that study is called as Toboggan study. Toboggan stands for Treatment of Booking Gestational Diabetes Mellitus. So what we did was, in Australia and also in India, where we participated from Chennai, and then in Sweden and in Austria, we collected women, and this is published in the New England Journal of Medicine. I'm very happy that I was also part of this 2023 part. This is the first and major publication of the Toboggan study. Just to show you the Toboggan investigators, this is led by the famous David Simmons, who also did the HAPO study, and most of the centers are from Australia, but we have and Helena Tate, who is here. You might have met her in the inaugural function. She also referred to the study. She is very much part of this. And then we have also Sweden, Austria, Vienna and India participating in the study. So what we did was, we screened a large number of women in these various centers in the early part of gestation, and we did a GTT actually. We did the same IIDPSG criteria which we use in late pregnancy, and we identified 800 women who had early GDM. 800. Out of these 800, this is a randomized clinical trial, RCT. So 400 we treated, that's called as the intervention group. 400 we did not treat at all. Okay? So you may say, is it ethical? You have found out that they have early GDM, now we are not treating them. Well, there is no evidence that it's safe. There is no evidence that it is good. This is the first major study. If you have to do an RCT, you have to do it that way. You may say, how do you know that the physician will then start treating? We didn't tell the physician that they had these 400 women. We didn't tell them that they had these 400 women. We told the physicians. Those 400 women just went through as if they had nothing. The women didn't know. The physicians didn't know. Nobody knew. So it is a proper controlled study. And then of course we had other groups, normal women, just to compare. And we treated them like we treat GDM women anywhere. Okay? The good news was that by treating early GDM, there was a significant reduction in the bad outcomes, the composite primary outcomes, which included preterm birth, birth trauma, shoulder dystocia, neonatal deaths, even NICU admissions were reduced. So those who needed admission to the ICU, that was also reduced, and this was highly significant statistically. So the first part of it, that treatment is effective and beneficial, was established. What about, is it safe? There were no significant side effects. I'll come back to that. If you treat them too early, when they have that 92, 93, they actually, babies became small. So that is the only thing. Otherwise, there was no adverse effects. There were no, we looked at hypertension, neonatal body mass, all that was not different between the groups. Now we came back to this question. You remember I said that 92 was criticized as being too low. So we had pre-designed it that we will look at women, we will treat everyone from 92 onwards, but when you analyze the results, we will divide them into a high band glucose and a low band glucose. What is a low band glucose? That is 92 to 94. And then 95 to 109 is a high band. Similarly, in the 1 hour value and the 2 hour value, we had a lower cut point and a higher cut point. The question is it worth treating these milder women also, or is it better to treat those who have little more severe? And the answer was very clear. If you had a high band, high glycemic band, you benefited the most. The ratio is 7.78. That means it is 7 times better than the women whom you don't treat. Now those on the low band, it was 2.48 better, so it is obviously good, but it crossed the midline. So it didn't reach statistical significance. So if you look at, is there evidence that it is beneficial to treat the low band? No, it's not statistically significant. But if it's high band, yes, clearly so. Next question we asked was, we said 20 weeks. Now some of the women had developed before 14 weeks itself, the GDM. Others had developed between 14 and 20 weeks. So we said, is there a difference between the two? And we found that if the women were diagnosed before 14 weeks, that means the earlier the women developed the GDM, they did much better. Of course, the others also benefited 5 times better, but it touched the line. So it didn't reach statistical significance. So 2 messages came out very clear from the main findings of the NEGM paper. For the first time in the world, we have evidence that treating early GDM is beneficial. There are no side effects. And the more severe you have, the better the results. The earlier the women get it, the better the results. So these were the primary findings. But Toboggan gave us an opportunity to do many, many more things. The first question which any government will ask or anybody will ask is, We already have so many late GDM women now. Now we are adding early GDM also. Is it cost effective to do that? That's the first question anybody will ask. So we did a proper cost effectiveness study. This is published in the Lancet E-Clinical Medicine. Each of those papers you can read. About 14 papers have already been published from Tobogum, and we have been happy to be part of all of them. So in fact, there is one issue of Diabetes Care published in February 2025, where Hannah's drawing is the cover of Diabetes Care, and there were 5 papers of Tobogum in the same issue. They had a separate section on Tobogum in Diabetes Care. Many of you would have seen that. I think 5 papers were there. This is a separate one where we looked at cost effectiveness. We found it's cost effective. So we should go ahead and treat with all the costs involved. The NICU admissions you save and everything else you save makes it cost effective. The next thing we asked was, okay, now we've got early GDM and late GDM. What happens if you just look at the outcomes of the late GDM women who did not have early GDM? Earlier we are not looking for early GDM, only late GDM. So everybody was mixed in that group. And we know, okay, treating late GDM overall has benefit. But what if you remove those who had early GDM and look at only those who had late GDM and treat them? Is there any benefit? What we found was there's no difference, which is not surprising to me. You diagnose somebody at 28 weeks and 6 weeks later or 8 weeks later they're going to deliver. What's the big thing of treating them in the last 5-6 weeks when the baby is about to come out? You go and now treat their diabetes. What do you expect? Nothing you will get. So all the results of the GDM so far has been because of the early GDM, which is missed all along. So in this paper we say that early GDM is in fact more important than the late GDM. The next thing we did was a recent paper where we looked at the postpartum conversion rates, how many women actually develop it. So overall, the early GDMs seem to convert more, and the good news was that if you look at the underlying ones, those who were treated and those who were untreated, if you didn't treat them, they developed the diabetes further. So treating these women early seemed to reduce the conversion to type 2 diabetes also. That means there's even more reason why you should treat the early GDMs. Now you may ask, all this is fine, but it's an Australian study. Is it relevant to Indians at all? That's what they said when HAPO was published, because Indians didn't participate in that. That's the reason why we participated in this. That question should not come. So the obvious thing is to break it down by various ethnic groups and see which ethnic group had more of early GDM. Surprise, surprise, it's the South Asians who had the highest prevalence. Look at the odds ratio for eGDM, highest. If you look at South Asians, compare them with Southeast Asians, East Asians, Middle Eastern, Maori, and the reference group is a white European population. So we are 2.43 times higher, and we have the highest risk. And this is not just Indians in India, it's Indians in Australia as well, South Asians, of course Bangladeshis and Pakistanis would have been included as well. So this message about early GDM is most relevant to us, and therefore we are the ones who should be screening for this. Okay? The next question is, why are these women developing early GDM? And why are they different from the late GDM? We are also looking at it. In fact, we are trying to collaborate with Russia for this, and we have Dr. Polina here from St. Petersburg. We have a collaboration probably going with them, but we also have another study which we are looking at. Our results are not ready, but there are 2 papers which have already come, and I'll just refer to one of them. Now here are insulin secretion studies represented in different ways: C-peptide, insulin secretion, secretion rate, beta cell function. L-GDM is late GDM and E-GDM is early GDM. This is a separate paper. This is a Western study. But you can see that whichever parameter you take, the early GDMs have less of insulin secretion. And that's why they're more severe. That's why they're converting more after their thing. And that is why they're developing it early. Because the beta cell function is more severe, so they don't have to wait until second trimester. By the time baby starts growing, first trimester itself, their diabetes comes out, because the beta cell function is not working properly. So now I'd like to conclude by saying that the earlier paradigm, which we have all been following is, yes, do a blood sugar in the first trimester, but that's not for GDM. That's to rule out pre-existing diabetes, type 1 or type 2. That's the only reason why we are doing, not look for GDM. GDM you look only in the second trimester. That's what we used to do. Now it's changed. Now you start looking in the first trimester, yes, to rule out type 1, type 2 diabetes, but also to look for early GDM, which in fact seems to be more important than the late GDM. And of course, if you don't have it in the early GDM, then you still repeat it once again because you will still pick up late GDM. Now you have to do a lot of studies doing early GDM and late GDM. Are they the same disease? Do they have the same genetics? Is the epigenetics the same? Is the metabolomics the same? The proteomics the same? This has opened up a can of worms, and so we have next 10 years we have to study all this to learn more about early GDM and late GDM, and we hope to do that. Meanwhile, has the world accepted this? Thankfully, yes. The first to accept it was Belgium. So the Flemish consensus, they have accepted, and they said, our country now, we will screen for early GDM. And what cut point did they use? They used the high band cut point. They said in toboggan, 95 and above was taken, and therefore we will use 95. If you're interested, they even tell you 95 what you should do, 126 what you should do, 95 to 125 is early GDM, and what you should do for that. They have made it their national guidelines. Australia followed, and Australian Association has said screen for early GDM. If you have GDM, you do this, you do that, otherwise you again screen for late GDM. They have also come out. ADA in 2025 has already said yes, screen for early GDM, but they didn't use the word GDM. Americans want to be different always. So they said early glycemic dysmetabolism, some other word they've used. They don't want to use the word GDM, okay? Essentially it's the same. A rose, whether you call it by any other name, is still a rose, okay? So they're not using the word GDM, they're saying it's glycemic something, dysmetabolism, something they call it, but they're saying yes, screen for it, they're saying. So 3 associations have already accepted this. So here are my take home messages, ladies and gentlemen. Early pregnancy blood glucose screening is mandatory, as it helps not only to identify pre-existing diabetes but also early GDM. Early GDM has a more severe insulin secretory defect, and that's why they're developing it compared to late GDM. Toboggan has shown for the first time that it's beneficial to treat, and particularly those in the higher band more than 95. So my prediction is that 95 will become the cut point in the future, and earlier you diagnose it. I understand that in Russia, even in 5th week and 6th week, they are diagnosing early GDM. We are saying before 14 weeks. When the lady says she's pregnant, do it then, because they may have that little glucose metabolism. No significant adverse effects of treating eGDM. It's cost effective. Indians have the highest prevalence of eGDM, and many countries are already accepting it. So if there's one message you must learn from this talk, I have 1 minute 46 seconds left. So early GDM or eGDM must be identified and treated by all of you. Every one of you, remember early GDM and do it. If you want to follow me on any of my social media, you can do this. If you check a QR code copy of this, you can join my WhatsApp channel. The advantage of joining WhatsApp channel is that every single day, 365 days, you will get a message from me. And if there's anything new which is coming out, you will be the first to know. Thank you.